So our next speaker is local, comes from University of Southern California. It's Jeff Gold. He's a professor of anesthesiology, pediatrics, and psychiatry and behavioral sciences at the Keck School of Medicine here at USC. And he's really one of the few people working with virtual reality in pediatrics. And we haven't heard a lot yet about pediatrics. We've heard a little bit about some of the concerns, and Skip showed a video of his nephews running around, I think there's nephews, with VR. But what is the evidence, what's the data about the impact of VR for kids? And what are the concerns that we might be thinking about? So we're going to hear a little bit about that now from Jeff Gold. Thank you for being with us today, and take it away.
Good morning, everybody. Thank you. This is very exciting. Being part of this virtual reality consortium has been a very exciting movement. So I will be speaking today primarily about pediatrics, and look forward to being able to speak to you about some of your concerns, questions, or interests in pediatrics. So I always like to start with this, said by the Dalai Lama, which is practice involves transforming ourselves, which is really in the area of virtual reality. We need to start with ourselves in order to bring that to our community and to feel confident about what we're doing, either evidence-based and or through clinical applications. So let's talk about pain a little bit. You've heard a lot about pain from a variety of presenters today, but really, what is it? This slide here is just to overwhelm you with what goes into pain, right? Because we recognize it's not just tissue damage anymore, but it has a whole network of issues. And the new technology, or the new sort of paradigm, is acute to chronic. And I go to a lot of pain conferences, and they talk about what is acute to chronic. It's a spectrum disorder or condition, so we have to really be thinking about it in that context. It also involves biomedical, which we heard about, movement, psychological, social, spiritual, etc. You may have seen some of this statistic put up by the Institute of Medicine back in 2012. Obviously, chronic pain, as well as recurrent pain and acute pain, is a serious concern and a serious problem, and clearly a really nice match for virtual reality. Be able to come in and develop some of these interventions. At the pediatric pain clinic at Children's Hospital Los Angeles, we see kids with a variety of chronic conditions, as you can see on this list here. And a lot of people don't know that fibromyalgia and complex regional pain syndrome is a condition that kids can have too. Most people think it's just an adult pathology, but we see functional pain disorders in kids too, as well as cancer-related pain, sickle cell pain. There's a host of conditions we see coming through our pain clinic. Pretty much all subspecialties kid come through our pain clinic. All right, so what is this? If the blue box is pain intensity, what are the types of things that go into our pain perception? Okay, because pain is a perception. Everybody experiences it differently, just as we see this image here on the slide. Does anybody know what that looks like, what that picture is? Anybody want to shout out? What is that? Liar. See, you guys are all good perceptors. You can see it, but most people see a face. Most people see a face, and that's what it is. But it's all based on perception and what we're taught. Pain is very similar. Cognitive contributions, attention, arousal, nociceptive or tissue damage all contribute to our understanding of pain, pain intensity, or chronic pain symptoms. All these bulleted items here are factors that have been studied in the psychological and medical literature to demonstrate their influences on pain and pain perception. So I always like to do a little shout out about that and demonstrate this puzzle, because that's really what we're dealing with. It's nothing very simple. It is not a simple problem. It's something we have to pay attention to and address a number of these issues. This is simplified in what I like to show. Emotion, cognition, all lead to pain. The prevention of it, the decrease of it, or the increase of it. So that positive and negative directionality is very important in the understanding of pain. That emotion can have, I have a lot of kids who come through and say, well, we went to Disneyland or Magic Mountain and I still had a headache. It's like, well, but excitement, endorphins and adrenaline can drive the system and also create more pain. So it's not just negative things that happen to the child or to the patient, but it's also positive experiences that can influence the pain experience. The neuromatrix theory of pain, I'm not going to go through this, but I think it's important that you know about it, and it'll probably come out in your slide deck or your handouts, so I wanted you to have that. So virtual reality and pain. This started quite a while ago with Hunter Hoffman and others looking at burn and wound care, and we've been doing procedural pain management at Children's Hospital Los Angeles with folks like Skip Rizzo. We started introducing it in the early 2000 when a headset was $50,000 and the Hydra set was $100,000, and now we're down to these $5 types of head-mounted displays that can host a smartphone. As of 2014, things have changed. Big game changers. So this is what's happening now. We're able to move into a more portable and more easily usable headset and smartphone technology. This is just a picture, as you've seen today, of kids wearing these headsets. At Children's Hospital Los Angeles, we've been collaborating with Applied VR and at USC to bring together technologies and software to be able to deliver interventions for kids across a variety of conditions. And obviously, we can't do this alone. As our last presenter said, this is a team effort. This is a team sport. We can't do it alone, so we need other people to contribute, whether scientists, industry, software, gamers, creative technologists, et cetera. It's a team sport. What we've been doing at Children's LA over the last couple of years has been, again, in phlebotomy, so blood draw. I mean, how many people like to have their blood drawn? Show of hands. Why is nobody raising their hands? All adults in this room, and you still don't like getting blood draw, so you can still think about what a kid experiences when they show up, whether a parent's holding them, whether the phlebotomist has to stick them multiple times, etc. It's not a pleasant experience. Nobody looks forward to it. We've been in cast removal, not so painful so much, but really it's anxiety producing. And that's when we get back to those models of pain. It's that combination of affect and pain that contribute to the concern around whatever the procedure is. So cast removal, they come at you with that big saw, and it's very loud, and the kids start tripping, and there's crying, and they're anxious, and they're nervous, and that makes the procedure more challenging for the cast removal. We also see that in radiology or even throughout the whole institution in IV placement. IV placement burns, it stings, you don't always get it the first time. It's a very unpleasant experience for a kid. And think about it. If you have a chronic condition, how many times are you coming to the hospital for medical procedures? This is not an annual checkup. I mean, you're coming in routinely, multiple times per month, getting stuck, CBCs, procedures, lumbar punctures, radiation, chemotherapy, physical therapy, occupational therapy. The hospital becomes a very unpleasant place, a scary place, right? And I think that's where VR partners well in a pediatric environment is how can we quell anxiety, nervousness, distress, pain, etc. How many of you have seen this picture? Nobody? Wow, 2 people? Wow, this is a novel VR group. I'm impressed. So this large headset was a study that was put out by Hunter Hoffman and Dave Patterson up at UW, where they were using this for wound care. You can see how the technology has changed. It's just nice to see a picture. A picture tells 1,000 words. There's a lot of models of VR. I'm not going to read this, but we talked about attention, about concentration on pain, et cetera. Implications for acute pain management and chronic pain management. You can see that there are top-down inhibitory processes. We've seen in the fMRI studies, the way that the frontal cortex is able to dampen incoming signals. There's attention models. There's distraction models that people talk about all the time, which I think really underestimates the power of virtual reality or other types of things, like even reading cartoons, even videos, et cetera. But VR really is better served and understood as a mechanism of action that is about an inhibitory process. I think that's how we can wrap our brain around that, not just as distraction. So to update the last presenters on PubMed, because you weren't sure whether it was current. So as of 9:33 this morning, okay, there's 8,000 plus articles in virtual reality. 2 years ago, there were 6,000. So we are really moving at a quick pace here with regards to the evidence base in virtual reality. And these articles, the 8,000, could be about technology, it could be about interventions, it could be case studies, it can be a pilot study, a feasibility study. These aren't all RCTs, but the number is increasing significantly. I'm in the space of VR and pediatric pain, which there's only been 31 published articles in that space. Still a tiny, tiny literature for pain. Again, whether it's acute or chronic. We see some chronic coming, like Balance's work at Stanford, looking at complex regional pain syndrome. Few studies are starting to come in on chronic. Most have been around procedures and acute. And you can see the bottom letters are maybe not so well. You can see the numbers of studies, the ages of the participants, how many 1 to 100, randomized control trials, exploratory, et cetera. There's been a whole variety in the literature. But I think it's good to recognize that we're having a literature and an evidence base that's increasing. And that's important. So you didn't miss out too much in medical school, because this is really kind of a newer thing that's happening, right? The evidence is mounting, and every time I get in a conversation with a person, I said, where's the evidence? I'm a scientist. It's not good enough to hear it's cool and it works. I need to see it in peer review. That's how I operate. I'm sure some of you are the same, and I see the evidence is growing, and that makes me happy. We've seen it in burn care, we've seen it in cancer pain, we've seen it in routine procedures, we've seen it in chronic pain. So the literature is mounting, and that's exciting for us as a group to see it changing. I think it's kind of obvious why it works for kids. I mean, I think Skip showed a demonstration with his niece-nephew. I mean, it's like fish to water, right? I mean, VR is just a natural for kids. They love video gaming, they love being on tablets, so VR is a natural for them. It commands a lot of their attention, their concentration. It draws them into environments that are real or animated and are exciting and engaging. Whether we do that visually, auditory, olfactory, tactile, the more senses, the better the play. We all know that. We've seen that in the literature. Some of the pain projects we've had at Children's Hospital Los Angeles, our very first study, back again in the early 2000s, was looking at phlebotomy. And this was a study that we conducted. And I had an opportunity today to meet Rebecca Allen, which was pretty exciting, because she created this environment. So in the parking lot, I'm talking to Rebecca Allen, and said, I've never even met you before from UCLA, but we used your environment. Are you here in the audience right now? Hello. Hi, Rebecca. Okay, that's exciting. So a little shout out to Rebecca for early advent of VR. It's very exciting, and we were able to use this with kids in phlebotomy and get a nice hit, a reduction in pain and anxiety, and that was very exciting. That was early with that $50,000 head-mounted display. So thank you for pioneering this work for us in pediatrics as well. I just wanted to appreciate you for that. We were able to demonstrate, again, a decrease in anxiety, a decrease in pain in the group that had the head-mounted display VR versus the flat screen. We started to delineate between the flat screen, the head-mounted, and this was done with Skip Rizzo and with Greg Rieger, who's a psychologist also practicing right now in the VR space. After that study, we did a study in radiology with IV placement with something that was a little more engaging, a little bit more game-like. It had speed, it had points, it had a finish line, a start line, so the kids were a little more engaged in that, had some rumble feedback on the ground when they were cruising down the luge. It looked good. They liked that. We introduced this with 20 kids, I think was our sample. It was relatively small, but we had a very robust finding that the kids who had IV placed with nothing had a big bump in pain, and the kids that were using virtual reality for the IV placement basically stayed the same, no significant change, versus a 3- to 4-fold increase in pain for kids getting IV placed without VR. So that was a pretty robust finding with only 20 kids. There's other studies in the literature on pediatric pain, acutely or in dental. You can see right here, 120 healthy kids who came in for who loves to have their teeth cleaned and planing and scaling and all that kind of fun stuff. So they did a very nice study with or without VR for this population, and they were able to demonstrate, again, decreases in pain, decreases in anxiety as a nice clinical trial of 120 kids. Then they did it with adult participants. I thought it was interesting because what a great design. They did a crossover design. Half the mouth was VR, half the mouth was not VR, and they were able to demonstrate that the adults that were using VR during the cleaning did better on that half of their mouth than on the other half. So good, just a really nice scientific study. And everybody loves Steve Martin, Little Shop of Horrors as the dentist. Everybody wants to be a dentist, so it's always a good time. There's also been studies looking at hypnosis and biofeedback and chronic conditions, and also experimental studies like Hunter did on fMRI and pain, your brain on VR, your brain off VR. I've done those studies also with children over at Children's Hospital LA to demonstrate that the brain activates in our expected pain matrix areas and decreases when you introduce VR in the MRI, and then the brain is less active in those pain areas, and it actually activates in frontal lobe areas that are related to cognitive inhibition and executive functioning and decision making, et cetera. So we've been able to demonstrate that with healthy controls as well as patients who have chronic conditions, pain conditions. So the most recent study that we just did in collaboration with Applied VR was we looked at about 150 kids coming through for blood draw with, in standard of care, randomized control trial. They were randomized to standard of care, randomized to VR. You can see, just looking at this picture, I mean, this is legit. This is not like a cherry-picked picture. This is the reality. This is reality, not mixed reality. That this kid on the top, he's already anxious. you know, and they're just touching his arm with the tourniquet. There's no needle coming yet. He's just already freaking out. So, and then the kid on the bottom is just relaxed, you know. It makes it easier for the phlebotomist to stick the kid if the kid's relaxed versus screaming and crying and moving. This is other standard of care, again, for IV placements or blood draw. This is the VR condition. That's not the Samsung. Just a quick shout out to this head mount we used with a phone, a Google Pixel, because of the age issue. And my IRB at Children's is not going to let us use a Samsung Gear VR for kids that are under 13 if the instructions and manual says it's not for children under 13, I can't roll it in. But this one was for 10 to 12-year-olds, so I was able to recruit another group. It's kind of silly, it's going to change, but that's federal regulations, and we have to pay attention to that. Beer Blast, which you may or may not have seen in the Applied VR booth out there, was a game that we developed for the purposes of VR for going through painful medical procedures, and we've been testing this routinely. It's such a problem. You know, there's so many environments out there. Which ones do we use? We wanted to study one, so we studied this one, right? But you could have a kid who could have 50 environments to choose from. And then you got to study all 50 environments, and you have to get a sample of 50 for each one of them, so you can do the math. It's a lot of kids. It's going to take a long time. So we studied one environment. But customization clearly is important over time. An 8-year-old girl doesn't want to do what a 16-year-old boy wants to do in the same type of game. So over time, this community is going to build that library, and it's going to be very exciting. It's going to be driven visually. It's going to be driven through music. It's going to be driven, you know, through tactile, et cetera. So, but for this study, we just used the one environment. You can see on the bottom corner where you're going through this environment with your head mount, and you're sort of launching these little Nerf balls, and you're bumping into these little bears, and they're giggling. And then it goes up some levels, and there's some masks, and there's other sort of interaction for the kids as they go through this environment. They don't have to use their hands. It's all driven through the head mount. So it's easy. It's simple. You slap it on them, and they're to the races. It's very easy for them. And they really enjoyed the game. They talked about it afterwards and gave us some feedback about that. This is what our kids looked like. Children's Hospital LA is very diverse, but majority Latino population. Almost 40% had a chronic medical condition and had blood draws in the past year of an average of 3. We use these measures, kind of standard pain measures, FACES pain scale revised on the top, and then these other analog scales for affect and pain intensity, and anxiety sensitivity and satisfaction and other demographics. So you can see the data here. The VR group and the standard of care group were mostly very similar across these visual analog scales, just descriptively speaking, and other facial affective conditions. But when we started looking at the results, we could see there were significant differences as reported by the caregiver, because we did a really nice design of the kid self-report, the caregiver report, and the phlebotomist report to triangulate the data so we can see what was going on. And we also videotaped it, so we have those still being evaluated right now for all the nonverbal and behavioral elements of the pain experience. And we also saw that the parents and the children, there was also a significant difference between the kids and the parents with regards to VR versus non-VR on facial affective. This was a really great finding because, again, customizing the virtual reality environment to a child is important, but also figuring out, like, who's the right kid for VR. Maybe not everybody. Sometimes kids would come in and they're like, I'm fine, and then they had the blood draw, and they were fine, and nothing changed. So what this picture shows is that there's an interaction with regards to anxiety sensitivity and anxiety and who responds better to the VR. So what we determined was that kids that had higher anxiety did better in the VR condition than kids who didn't have high anxiety sensitivity. And anxiety sensitivity is this idea that your heart's racing, your blood pressure's going up, you're feeling physiological distress. Not just I'm worried, but it's more about that body, physical, somatic experience. And so those kids seem to be the sweet spot of the tennis racket, right? That's our group. And so that was newly learned information, which was very exciting. The qualitative, every study these days has to be mixed methodology. We do quantitative and qualitative. We want to hear from the mouths of the phlebotomists and the mouths of the parents and the kids, what was that like for them, right? In the early days, that's all we had, satisfaction data and what it was like for them. And you can read these on your own, but people felt good about it. They want to have VR for every blood draw. They want to have VR for IV placements. Kids talk about wanting it for other medical procedures, telling other kids that they should do it. And, so it's this whole ethical concern, like, wow, we really need to bring this into the hospital and have it available for everybody. That would be the best thing to do. We got published in Wall Street Journal, I think, with some others from our group here at Cedars, using VR to reality to ease real pain. I don't know what that was just their title, but it's, you know, any PR is good PR. So that was nice that we got that here at Children's and at Cedars. We were at the Society for Pediatric Psychology, which is a big convention for me, to hang out with a bunch of other pediatric psychologists and talk about what we're doing. So we had a poster that was presented there. And then there's been a lot of publicity since this study rolled through the hospital. And we had a publication in the Journal of Pediatric Psychology at, I think it was January or end of December this past year, on that 143 kids. So again, contributing to the evidence base is what I want to do. The technologies are amazing. They're incredible. The kids like them. But I want to see us as a community continuing to develop and contribute to the evidence base, because that's what's going to make a difference, I think, in the ultimate adoption of VR for health and mental health. Future directions. This is kind of what I just said. Utilize randomized control trials. You have to do that. Scientific rigor. Continue to differentiate pain, anxiety sensitivity, procedural pain, pain intensity, chronic pain, acute, recurrent, past pain memories, starting to filter that out, you know, in models where we can control for certain factors and figure out what's contributing. Incorporate neurochemical, physiological, observable measures, video recording. Get those types of body and mental self-report measures collectively. That is going to be a better metric for us to understand. Investigating the neurobiological correlates, which has been done a little bit. I still think that determining mechanisms of action. Look, I submit to NIH for grant funding. Maybe some of you do as well. I have news for you. If you can't talk about the mechanisms of action, or you can't give a theoretical underpinning for what's going on psychologically or biologically, you're in the round file. It's over. Okay? It's not good enough to have just a great, interesting, cool technology. You have to understand how and why it's working that particular way. And if you want to study that because you want to contribute, that's terrific, but we really have to understand those other mechanisms. Incorporate the use of complementary and non-pharm interventions. This big opioid crisis, honestly, I don't see it huge at Children's LA. Doesn't mean that we don't have opioid issues, but it's not as big of a crisis as people are making it out to be at Children's Hospital. I recognize it's a problem in our country, and I think that's legit, but we have to figure out other ways of treating our patients who have chronic illness or chronic pain other than narcotics. I think VR and medications together, that being said, it's a complement. I don't expect that VR is going to take over the world, although many of us would like to see that happen. It's not going to replace or dethrone the role of medication. You know, you have to continue to speak to medications and that role and the importance of that. The red highlighted one, I've had this slide, Skip's probably seen it 25 times or 30 times. I mean, I've had this on here since the early 2000s, right? But it's happening. I'm looking at you. Like, my reality is now an actual reality, not just an imaginary fantasy, that gaming technologists are coming together and industries coming together to really put effort into us delivering better, ecologically, efficaciously sound environments of virtual reality for health and mental health, which I think is very exciting. And so this is happening, and that's exciting to me. Continue to marry technologies with behavioral interventions, which we saw presented in the last presentation. It's developmentally appropriate, it's developmentally fitting, and we have to pay attention to that. Again, one size does not fit all, right? One size does not fit all. This is my cute little daughter. I was just blown away, like, you know, rolling into the mall, and then there's these VR games, amusement games that are there. I mean, it's really come into the water. And honestly, when I started seeing commercials, Samsung commercials with kids and seniors playing with VR and et cetera, I think it was a Samsung, I was like, wow, this is unbelievable. Because it used to just be ivory tower, experimental lab. You know, we were just sort of in our own head about this. But it's really been nice to see it become this reality. On that note, I will end. Thank you for your attention. Thank you for your time. And I look forward to answering questions later on. Have a great experience today. And hopefully talk to you very soon.
Awesome. Great job. Thank you.
Thanks.